Welcome to Case Series 1, and here we explain some topics with clinical cases. Okay, so let's deep dive into the cases. Just imagine a 45-year-old male, a 45-year-old male, okay, presented in OPD, or rather than say you can say in emergency with altered sensorium, okay, or you can say in the delirium stage. It is the when you take a history in the emergency room fastly, very fastly, the relatives are saying कि उसको अल्कोहल का हैबिट है, बहुत दिनों से अल्कोहल पी रहा है, अल्कोहल छोड़ भी नहीं रहा है, डायग्नोज भी हो गया उसको कुछ डिजीज, लेकिन वो अल्कोहल को छोड़ नहीं रहा है, मतलब ही इज ए क्रॉनिक अल्कोहलर, अल्कोहल यूजर. सेकंड थिंग, फर्स्ट थिंग, he is a chronic alcohol user. Okay. Second thing, he is altered from last 2 days. Okay. First thing comes in mind, and when you see he's little bit obese, either it is obesity, or you can say he can be thin, or you can say he have ascites. Okay. These are the three things you see in that patient. A 45-year-old male comes in your emergency at night with altered sensorium, or you can say delirium. Okay. If you ask patient, if you ask the patient, he's confused. Okay. Uh, you are asking something and he's answering something different. He's a chronic alcohol user. The history is of 2 days, and he can be obese or thin, or can be having ascites. Okay. So by this, a 2 day history and alcoholic user, normally in the clinical case discussion, I have to go. I have to plot a thing that go with my topic, else there are thousand things we can discuss. So imagine it is 2 days history and 45-year-old male. If the most common cause in India of altered sensorium is nothing like that, but usually when we saw in the patient in my hospital, we see that a 45 or 35-year-old male comes in altered sensorium. We think about TB. We think if in the young TB, and we can think about this disease what we are reading, and if it is the elderly patient, we first think about metabolic syndrome. Okay, whenever it is the must to do, whenever a elderly patient comes, we always have to look for metabolic encephalopathy or metabolic syndrome. Okay, and for any age we can have encephalopathy also, we can have meningitis also. There are multiple things of delirium in the patient, and this table perfectly describe this. Okay, that what are the differential diagnosis of delirium, what type of patient can come with the different delirium, okay, in your emergency OPD. Okay, so in this case the patient have history of alcohol abuse. Okay, alcohol abuse, first thing. Second thing, a history of 2 days. Okay, and he is delirium, or we can say mental confused. By the history, when you go the patient, you do metabolic thing, you do all the investigation, but one investigation you especially mention in the patient is serum ammonia. Okay, when you say uh, it is normal range of serum ammonia is 60, around 60, normal range is serum ammonia is 60. When you do the serum ammonia test in this patient, all the metabolic parameters are almost normal. But when you do this test, serum ammonia, it is around 93. Okay, it is around 1110. It is around 72. Means it is increased. The serum ammonia is increased. Okay, it is confused, and so this is the classical case of hepatic encephalopathy. We are reading the topic hepatic encephalopathy. Okay, because he is alcoholic, her liver is not working properly, serum ammonia is increasing, it goes into the brain, changes to the mental ability, it changes into the glutamine and affect the brain anyhow. So this is the thing. A patient is 38 or 45-year-old male present in your emergency with altered sensorium. You do the serum ammonia test and other parameter. The serum ammonia is raised, and you think about hepatic encephalopathy. You know, this is the most common question. Many questions asked from this in the UPSC CMS 2024. There are two questions from this topic only. Okay, so you do the investigation serum ammonia. It is raised. Okay, it is mostly in the 80% cases the serum ammonia is raised, but not in the 100% cases. It's not sure that if the serum ammonia is decreased, also can have patient have hepatic encephalopathy because there are multiple etiology. The serum ammonia is the most common cause of hepatic encephalopathy. Other cause of hepatic encephalopathy in the etiology you can read in the Harrison and your Marrow notes also. Mercaptan, phenol, aromat aromatic amino acid, manganese, GABA, and octapamine and free fatty acid. These are the other etiologies. The most common being serum ammonia. Other etiologies. These are the other etiologies. Okay. So if you divide the serum ammonia, if you divide the type of hepatic encephalopathy types, there are three types. Okay, type A, type B, type C. Type A, it is the fulminant hepatic failure that produce hepatic encephalopathy. Okay, and it is in the here the cerebral edema is increased because of glutamine. Okay, type second is due to after TIPS tip surgery. Okay, and type C is the due to cirrhosis, portal hypertension that we are reading here. It is the producing hepatic encephalopathy, and this is the most common type, cirrhosis portal hypertension. Okay, so in the patient we read the serum ammonia is the etiology and there are type, and this is the type 3. Okay, what happen usually in these patient, either urea cycle is dysfunction by the liver damage. What are the cause? Either urea cycle is damaged, or the there is shunt, portosystemic shunt. Okay, portosystemic shunt means the blood is not going into the liver, it is shunting. Blood is direct going into the vein from GIT. Okay, shunt of shunting of blood. Okay, the third thing is bacteria, and you are taking high protein diet. These are the three etiology. Okay, that lead to serum increase in the serum ammonia, and it is absorbed by the non-ionic diffuse, and that affect the brain. And in the effect, the pathology question is which type of cell is affect. It affect astrocyte type 2 cells, and if you read astrocyte type 1 cell is affected in the Alzheimer disease. Okay, astrocyte type 1 is affected in Alzheimer disease. Okay, so you if you see the actually it the serum ammonia, if serum ammonia changes in the glutamine in the CSF, it increase the uh, edema and many things. Second thing, it is a toxic part. So glutamate is decrease in blood and increase in CSF. Okay, this is thing. The next thing is what are the precipitating factor? That is very important. There are multiple precipitating factor that increase the chances of hepatic encephalopathy. Just like patient, this is the question of UPSC CMS 2024. Okay, the precipitating factor is there are multiple precipitating factors, just like dietary protein, constipation, GI hemorrhage, sepsis, you can mean infection, alkalosis, hypokalemia. They are asked this hypokalemia, hypovolemia, hyponatremia, dehydration, CNS drug like GABA, uremic symptoms. These are the things that are the precipitating factor. You can read in notes what are the precipitating factors, but I am just making you understand these things. Okay. Second thing, as the patient comes in altered sensorium, which criteria you use in this patient? You use West Haven criteria. And if you see the West Haven criteria, there are five grades. Okay, one, two, three. There are four grades. There are four grades. As you know, the patient, sometime if you ask from the patient attender, they are say कि सर है ना पेशेंट को 2 दिन से नींद नहीं आ रहा है. This is means altered sleep pattern. Altered sleep pattern is the grade one. Or if you say he is saying he is the behavior abnormal, personality issue. Just like in my case, a patient comes and वो आते ही क्या है, गालियां दे रहा है बहुत जोर जोर से. आप उसका हाथ नहीं पकड़ सकते हैं. आपको इतनी बुरी हालत है उस पेशेंट की, आपको उसको हाथ बिल्कुल अटैच करके रखने पड़ेंगे. दो लोग उसके हाथ पकड़ रखे हैं, दो लोगों ने उसकी लेग पकड़ रखे हैं. तो इतना ज़्यादा बिहेवियर एबनॉर्मलिटी है, बहुत ज़्यादा डिसोरिएंटेड है. और स्पीच स्पीच इतने तेज गालियां बक रहा है वो, मतलब ऐसा मान लीजिए आपका वार्ड पूरा गालियों से चिल्ला रहा है. मतलब आपका एडमिशन चल रहा है और वो ही एक पेशेंट है जो गालियों में चिल्ला रहा है बस. दिस अ पर्सनैलिटी इशू एंड दिस कम्स अंडर ग्रेड टू, बिहेवियर एबनॉर्मलिटीज. Okay, if the patient is semi-stupor with bizarre behavior or patient in the coma, these patients they have typical EEG finding, triphagic EEG. Okay, you know it about it. Triphagic EEG, I will add. The feature about here, the important thing about here, in the West Haven criteria, the grade 2, when the patient is abnormal behavior, we do one test and this is patient is shows एस्ट्रेक्सिस. वी हम क्या करते हैं, पेशेंट को बोलते हैं कि अपने दोनों हाथों को सामने लेके जाना है और उनको क्या करना है, पंजों को अंदर की तरफ मोड़ना है. एंड दिस नॉज इज फ्लैपिंग ट्रेमर्स, यू ऑल्सो नो. दिस इज नॉट ओनली द कॉज, मतलब एस्ट्रेसिस का एक मोस्ट कॉमन कॉज ऐसा नहीं कि हेपेटिक एन्सेफेलोपैथी है, लेकिन देयर आर मल्टीपल कॉजेज हेपेटिक एन्सेफेलोपैथी. वन ऑफ द कॉमन वन ऑफ द कॉज ऑफ एस्ट्रेक्सिस इज हेपेटिक एन्सेफेलोपैथी. ये आपको याद रखना है. अब आपको करना है क्या इन पेशेंट के अंदर, यूजुअली इन पेशेंट के अंदर आपको करना है, आते ही उसको क्या देना है, लेक्टोलूज. यू सी इन द योर नोट्स द ट्रीटमेंट का मेन पार्ट क्या है, लेक्टोलूज. एक्चुअली लेक्टोलूज कर क्या रहा है, सीरम अमोनिया को एक्सक्रीट आउट करने में हेल्प कर रहा है. ओके, उसको डायरिया लगेगा, डायरिया से फटाफट एक्सक्रीट आउट होगा. सेकेंड दर्ज इज रिफाक्सिमिन. Usual dose we can use is 55 mg BD or 400 mg TDS. In our hospital, it is available as 550 mg BD. You see it, rifaximin, it changes the bacterial culture of the patient's gut and प्रोटीन जो बैक्टीरिया होते हैं जो सीरम अमोनिया में जो चेंज करेंगे प्रोटीन को यूज करके, वो बैक्टीरिया को किल करेगा. अदर जस्ट लाइक वी यूज नियोमाइसिन बट इस साइड इफेक्ट बहुत सारे हैं. ये यूपीएससी का क्वेश्चन था इस साल का. And there are acarbose also and there are lola also and one important thing is sodium benzoate, जो कि आपने कहाँ पे पढ़ा है, आपकी यूरिया साइकिल में. ओके, तो दो इंपॉर्टेंट चीजें वो है कि सीवीटी, इसमें एक चीज इंपॉर्टेंट है कि सबसे इंपॉर्टेंट चीज क्या है, मतलब एक चीज है कि सीरम अमोनिया, जो सीरम अमोनिया का लेवल है, सीरम अमोनिया लेवल डिजीज की सीवियरिटी को शो नहीं करता है. ओके, डोंट शो डिजीज सीवियरिटी को शो नहीं करता, इंपॉर्टेंट है. दूसरा, एक का सीरम अमोनिया पेशेंट 72 है, एक का 101 है. दैट डज नॉट मीन कि जो 101 वाला है उसका वो ज़्यादा अल्टर्ड रहेगा, ऐसा कुछ होगा. ठीक है. ओके. एंड नॉर्मली मोस्ट हिपेटोलॉजिस्ट क्या करते हैं, सीरम अमोनिया लेवल पे क्या करते हैं, रिलाई भी नहीं करते हैं. ओके, इन दिस पेशेंट के अंदर आपको इंपॉर्टेंट चीज़ जो मेन इसका साइड इफेक्ट होएगा वो होएगा, जो मेन जो एक साइड इफेक्ट है जो बहुत डेंजरस रहेगा वो है सेरेब्रल इडीमा. ओके, सेरेब्रल इडीमा को कैसे मैनेज करना होता है, यू बाय दी मैनिटोल एंड जुडिशियल यूज ऑफ फ्लूइड. क्योंकि इससे क्या होता है, इडीमा होगा तो उसमें क्या होगा, हर्निएशन होने के चांस भी ज़्यादा होंगे. ओके, rest of thing, predominant cell astrocyte type 2 grading and all thing I told you, rifaximin, carbos, you know. Sometimes you have to go for electrolyte and hydration also for the patient, and zinc supplement is also uh, noted in some studies that it is also helpful and relatively harmless in these patients. Okay. Next thing is what are the complications of cirrhosis? We only read one complication of cirrhosis, and what we read today, hepatic encephalopathy. It is the very commonly present in the uh, or IPDs. Okay. Next thing, you have to rectify these things. What are the complications of cirrhosis? Important point. Next thing, we read. Actually, I did multiple sites. Don't know why. In the treatment part, we one thing we missed is The last part, if it is occurring again and again, we can go for treatment as liver transplantation. Okay, here, these are the contraindication of liver transplantation. You have to ratify these, understand these, just like the active substance abuse, absolute contraindication है, untreated sepsis, uncorrectable life limiting congenital anomalies है कोई, extra hepatobiliary malignancy है कोई, metastatic malignancy to liver है कोई, cholangiocarcinoma है, AIDS है, लाइफ थ्रेटनिंग सिस्टमिक डिजीज है, इन सब केसेस के अंदर आपको दीज आर द एब्सोल्यूट कॉन्ट्राइंडिकेशन. एंड एज आई टोल्ड वी यूज मेल्ड, एक्चुअली MERD नहीं, इट इज MERD ग्रेड 3 तो किसी और की है. वी यूज दी which score? MELD score. Okay, MELD score and MELD sodium score. These are the two score we use, and you have to ratify what thing in the MELD score. What we use? It is the bilirubin, it is the INR, and it is the creatinine, and it is the sodium that is used in the MELD sodium score. There are one also score that confuse me here. It is the MDRD score that is used for the GFR estimation, and it used for the eGFR estimation, and it use GFR, age, serum creatinine, and patient is male, female, or it is Asian or black. These are the GFR. Remember, if the GFR is less than 60, it is known as chronic kidney disease. And we also use other formula, Cockcroft Golf equation. I hope